Hi, my name is Jack Aiello with The Patient Story. I'm a 28-year multiple myeloma survivor and advocate from the San Francisco Bay Area in California. I'm often asked, in fact, what did I do to be around for 28 years? Most of my treatment was my first 8 years when I had a tandem autologous transplant, but that didn't work very long for me. I was in a clinical trial, and that didn't work too well either, and nor did other uh, chemotherapy treatments. So I actually had one option left for me, and that was called an allogeneic transplant, where donor stem cells are given to me. But the growth of myeloma treatment continues at a rapid pace. And the landscape of all of those treatments is really quite incredible. And we're going to look at that today at one of the newest treatment areas. We're happy to welcome Dr. Alfred Garfall, a myeloma expert at the Penn Medicine. Dr. Garfall, thanks for being here with us today. Can you tell us more about yourself and what drew you to the study in myeloma?
I'm an assistant professor of medicine at the University of Pennsylvania Abramson Cancer Center. I'm part of a really nice group of 6 physician investigators here who focus on multiple myeloma, taking care of multiple myeloma patients, conducting clinical trials with new multiple myeloma therapies, and also doing preclinical studies, so studies in the laboratory looking at developing new therapies for multiple myeloma.
And just so we understand, because that's what we're going to focus on today, immunotherapies, and specifically bispecific antibodies. But can you tell us more in layman terms, what are immunotherapies and then what are bispecifics in myeloma?
Sure. So broadly speaking, an immunotherapy for cancer is any therapy that tries to induce the patient's immune system to fight the cancer. The success of immunotherapy for cancer, not just in blood cancers, but in other cancers, has been one of the big success stories in all of medicine in the last decade or so. But you can, if you think of immunotherapy, you can go back even further to allogeneic stem cell transplantation. And the whole idea of allogeneic stem cell transplantation, which has been a therapy for blood cancers for decades now, is to utilize the immune system of a donor, of a stem cell donor, to recognize the cancer in the patient and try and kill the cancer. So you can think of an allogeneic stem cell transplant or a bone marrow transplant as an immune system transplant, where if you're the patient and your immune system has failed to eradicate your cancer or your multiple myeloma, maybe if we give you the immune system of another patient, that immune system of the other patient will be able to recognize your myeloma as foreign and attack it. And that strategy has proven successful for a variety of blood cancers. Now, what we've seen in the last 10, 15 years or so is the success of approaches that are more pharmacological. So developing drugs, and as opposed to procedures like stem cell transplant, that can replicate that immunologic effect, maybe in a more targeted way and in a way that's a little bit safer, because an allogeneic stem cell transplant is still kind of a high-risk procedure. And so we've seen the success of strategies to induce immune responses against cancer play out in a number of different cancers. Been with these approaches, these techniques that really harness T cells, which are a part of the immune system that it probably plays a role in fighting cancer, but also, of course, like the main purpose of the immune system, fighting infections. Approaches that what we call redirecting T cells. And so T cells are these cells in your body that are kind of trained on specific proteins. And these are typically proteins that are found in bugs that make you sick, bacteria, viruses. But it turns out that those T cells have the ability to kill cancer cells. But in patients with an established cancer, those T cells aren't doing the trick. And so these latest therapies that have come down the pike in blood cancers, namely CAR T cells and bispecific antibodies, the approach they take is to redirect all the T cells in your body away from the virus or bacteria that they might have been designed to treat and towards the cancer cell. And CAR T cells and bispecific antibodies do that in a similar way, although there are some important differences between them. And so that approach of CAR T cells and bispecific antibodies to redirect the T cells in patients' bodies towards their cancer has been successful now. And we see that in the approval of FDA approval of therapies, of CAR T cell therapies and bispecific antibodies to treat initially B-cell acute lymphoblastic leukemia, and then non-Hodgkin's lymphoma, and then subsequently multiple myeloma.
So immunotherapy is a way, hopefully, to get my own immune system smarter about fighting my myeloma.
Exactly.
You mentioned both CAR T and bispecifics as examples of myeloma immunotherapy treatments. Can you quickly say how do they differ from one another?
Sure. So both these approaches, they're trying to get your T cells to recognize your multiple myeloma cells by a molecule on the surface of the myeloma cell. And so we want a target on the surface of the myeloma cell that can distinguish the myeloma cell from healthy cells in your body. And then we want to find a way to get the T cells to recognize that target and thereby kill the cells that express that target, namely the multiple myeloma cells. So the way that's done with CAR T cells is that T cells are taken out of your body and brought to the lab. And those T cells are genetically engineered so that those T cells have on their surface kind of a warhead that can recognize that target on the multiple myeloma cells. And then those cells are infused back into your body after that genetic engineering. And with that engineering and the warhead, those cells will then be able to recognize the target on the surface of the multiple myeloma cells and kill the multiple myeloma cells. And so that's how CAR T cells work. It's a little bit of a complex process, as you can imagine, because you have to, in order to create this therapy for a patient, you kind of have to make a product for that particular patient. So every patient has to have the CAR T cell therapy manufactured for them using their own cells. There aren't a lot of therapies that work that way. There aren't a lot of, no other myeloma therapy works that way, where you have the therapy manufactured for the particular patient. Most myeloma therapies are drugs that you go to the pharmacy and you take out of the pharmacy, and the patient takes them themselves or give to the patient. So that's a complexity to CAR T cell therapy that's different from other multiple myeloma therapies, but is quite effective. And we can talk more about how well it works for multiple myeloma patients, but it's a really effective new therapy. Bispecific antibodies try and do that same thing, but in the form of a drug. And what a bispecific antibody is a biologic molecule that's got kind of two arms to it. One arm grabs a T cell, and the other arm grabs a multiple myeloma cell. And it grabs a multiple myeloma cell by recognizing a target on the multiple myeloma cell, just like the CAR T cell does. But this bispecific molecule that has two arms, it can basically grab a myeloma cell with one arm, grab a T cell with another arm, and bring them together and force that T cell to recognize the multiple myeloma cell. So it's the same basic strategy as the CAR T cells, in that we're trying to get the T cell to recognize the myeloma cell, but you're doing it in the form of a drug rather than through this complex genetic engineering process. And so that has the advantage of not requiring that T cell extraction and patient-specific manufacturing. It's just a medication like any other antibody for myeloma, like daratumumab or elotuzumab. It can be pulled off the shelf and given to a patient, and you can get very similar levels of T cell activation against the multiple myeloma with bispecific antibodies that you can get with CAR T cells. And so it really is an amazing feat that you can get the same kind of clinical effects with bispecific antibodies as you can with CAR T cells, but with the simplicity of a drug, of a pharmaceutical that can be given, without that complex patient-specific manufacturing.
I know that we have one bispecific antibody called Teclistamab, also known as Tecvayli, that's currently FDA approved. Can you share how it's given and who it's given to and What are the typical responses and how long do they last?
Sure. So teclistamab, yeah, is the first approved bispecific antibody for multiple myeloma. It recognizes this molecule called BCMA. And so a lot of the new immunotherapies against multiple myeloma recognize BCMA on the surface of myeloma cells. And so we have the two CAR T cell products that are approved for myeloma called Abecma and Carvykti. They recognize BCMA. And then teclistamab, a bispecific antibody, also recognizes BCMA. And so teclistamab is given as a subcutaneous injection, which is quite remarkable, actually. If you think about how simple it is to give a subcutaneous injection compared to CAR T cell therapy, it's an impressive amount. It's an impressive progress in terms of our treatment options to have that kind of potent immunotherapy that can be administered as a subcutaneous injection. So it's given as a subcutaneous.
I was just going to say,
similar to Velcade.
So similar to Velcade, or many folks on Dara now, daratumumab.
Exactly.
Okay.
Yeah. But because of these bispecific antibodies are actually they're more potent than in terms of how they activate the immune system than something like daratumumab. So the dose of the antibody is actually quite a bit lower. And so while Darzalex has to be given as that kind of long 3-minute subcutaneous injection, teclistamab is just a really quick subcutaneous injection. But that's a minor point. It's given as a subcutaneous injection once a week. Although we on the clinical trial, it's been shown that you can really extend that dosing to be every 2 weeks or even every 4 weeks. And I think we're going to get some more data on that. But right now, the way it's approved by the FDA is as a weekly subcutaneous injection. Because of some of the risks of teclistamab and the concern that it might kind of activate the immune system a little too quickly in patients and lead to some side effects, the way it's given, the first couple doses are given as little steps up. And so you start with a small dose, then a couple days later get a medium dose, then a couple days later get the full dose. And those first few doses are typically given in the hospital so that if patient's immune system gets a little bit overactive, that can be managed quickly in the hospital. But then that risk seems to be really confined to those first few doses. And once you get past those first few doses, you really don't have that risk with the ongoing dosing. And so after those first few doses, it can be given in the outpatient clinic without concern about that toxicity for the rest of the time that you're on the medication. The way that it's given right now is that you do kind of keep getting it as long as it's working. And so we may hear more about alternative strategies that don't give it forever. Right now, as long as it's working, patients continue to get the medication on a weekly or every 2-week basis.
And patients are showing responses to the drug, I guess so, if it was approved.
Yeah, they are. And so in the study that led to its approval, it's approved by the FDA as an accelerated approval. So it hasn't the big phase 3 clinical trials that compare it to other therapies for long-term outcomes, like how long people live with myeloma, how long it keeps the myeloma under control. Those studies haven't been completed yet. But because it showed really promising activity, just in itself in patients with myeloma that were really running out of treatment options, it showed a response rate of about 65% as a single medication, which is really impressive as a single medication. And what was really impressive too was that most of these responses were really good responses. And so we have these different criteria that you may be familiar with in myeloma: partial response, very good partial response. Basically, the vast majority of these cases were either very good, of these responses were either very good partial responses or complete responses. What that means is that patients had, almost all patients who responded to the medication had at least a 90% reduction in the amount of multiple myeloma in their body. And so that's really impressive for patients who are really running out of treatment options, whose myeloma had become resistant to all the standard medications for a single drug to have that kind of response, especially with the simplicity of kind of a subcutaneous injection. That's really impressive and promising results. And so we're really excited that it's out there now, and we're able to use it to treat patients who are not on the clinical trial.
When I think back to the approval of terrific medications like Velcade or Revlimid or daratumumab, when they were tested and given as single therapies, the response rates for those were typically in the 30% neighborhood. And so you're saying that teclistamab is double that in terms of patients achieving a very good response.
Yeah, that's right. So and if you think about not just the response rate being that much higher, but the responses being so robust in terms of 90% reductions in myeloma. So if you think about, with time, we've learned, once we got past those phase 1 studies of Velcade and daratumumab, those medications have been moved into earlier lines of myeloma therapy and combined with other therapies. And that progress has led to many, many years of improvement in the expected survival of multiple myeloma patients. And so that's what's so exciting about medications like teclistamab and CAR T cells. If these therapies can show so much promise in patients whose myeloma has become really, really aggressive and refractory to therapy, we think that there's going to be even more impact when we can use these therapies a little bit earlier on in the disease course, and perhaps even in combination with other therapies, in the same way that daratumumab and Velcade, when they showed 30% response rates early on, or initially, when you started combining them and moving them into earlier lines of therapy, we saw those benefits magnified many times. And so we're optimistic that we're going to see that same trend with some of these newer immunotherapies.
But you also said that at least the first week or first couple of weeks, I'm going to be in the hospital while I get low dosages of teclistamab, and then subsequently those dosages are increasing as long as my side effects are not, are being able to be managed. So can you talk about side effects from these bispecifics?
Yeah, absolutely. And this is where some of the complexity comes in. And I think, while I've been kind of speaking so far about, what great progress this is, some of the devil is in these details. And so we do worry when the medication is given, as I said, that it can amplify, activate the immune system too quickly, and that could lead to some complications. And so one type of complication is this syndrome called cytokine release syndrome, which is, in its simplest form, is just some fevers. But if it gets out of hand, it can progress to difficulty breathing, low blood pressure, even potential for, needing to be in the intensive care unit, and even potential, for patients to even pass away from this complication. If you look at, across the experience with these types of therapies in different diseases, there have been patients who have passed away from cytokine release syndrome getting out of hand. And so that's why patients are watched in the hospital with those initial couple doses. Now, the experience with teclistamab has been very favorable in that patients who get this cytokine release syndrome, or CRS, for the most part, have it in a mild to moderate form that is very manageable. And so we have not really seen patients in the studies with teclistamab, pass away from complications of CRS. But in theory, we know it's possible. And that's why patients are in the hospital. There are really good medications we can give to calm down that inflammation. And so if somebody has a fever after they get that teclistamab dose and it starts to get a little out of hand, maybe it's not just one fever, but it progresses to 2 or 3 high fevers, you can give them another medication that can calm down that inflammation, and then allow the subsequent doses to proceed and still get the same therapeutic benefit against the myeloma, but without additional fevers and cytokine release syndrome. And so we think of this as a very manageable complication. It is the same kind of thing that can happen after CAR T cell infusion, and we manage it with very similar ways. But that has led, I think, in the early experience with this medication, its use is kind of right now a little bit restricted to places that have some expertise in handling that complication, and that have, not every oncology office is hooked up to a hospital with a specialized oncology unit that's capable of managing some of these complications. And so right now, the medication's only been FDA approved since October, at least in our region. It's mainly the academic centers that are using this medication. I do think with time, though, especially because there are a number of bispecific antibodies that are being developed, not just for multiple myeloma, but for lymphoma and other cancers, that the oncology community is going to get more comfortable with these toxicities and have pathways in place to handle them even at a community oncology center or at a community hospital, so that these drugs are available not just to patients who are connected to a big center, but to patients all around the country and world.
I've also heard that one of the side effects to be focused on is the possibility of infections.
That's absolutely right. Yeah. So I mentioned that, there's those inflammatory reactions that can happen with the first few doses. Unfortunately, those are confined to the first few doses and not an ongoing problem. As patients get this medication for months and months, though, we've learned that it is a pretty immunosuppressive medication. Even though it's just one medication given, as opposed to, there's once you get beyond those first couple doses, there's no dexamethasone. We're not combining it with other drugs or chemotherapies. But even as a single medication, it is pretty immunosuppressive. And so we do worry about infection over the long term. Now, infection is a concern we have in any multiple myeloma patient with any therapy, but we do think maybe the risk is a bit higher with Teclistamab and other bispecific antibodies that target BCMA. What we've learned, though, is that there are some things we can do to manage that risk. We are generally recommending that patients take some prophylactic antibiotic against a particular type of pneumonia called pneumocystis pneumonia. And so the most common way we handle that is to give Bactrim, which is an antibiotic that's very good at preventing that type of pneumonia. And the other thing that we do is give patients IVIG, which some of the patients on listening may be familiar with IVIG. IVIG is antibody replacement therapy. And you can think of it just like, if your red cell count gets low, we can give you a red cell transfusion. If your platelet count gets low, we can give you a platelet transfusion. If your antibody level gets low, we can give you an antibody transfusion. An intravenous immunoglobulin is basically a transfusion of antibodies that can raise your antibody levels. And the reason that's important with Teclistamab is because Teclistamab does kill the normal plasma cells in the body. So we think of myeloma plasma cells as being the cancerous plasma cells, but your body also has normal plasma cells. And the normal job of plasma cells in your immune system is to make the antibodies that help you fight infection. And patients who get Teclistamab over the long term, the drug really lowers the level of normal plasma cells in the body and therefore lowers the amount of normal antibodies being produced in the body. And so we can get around that by giving patients periodic transfusions or infusions of antibodies that have been collected from donors, just the way, in the blood bank, you have red cells and platelets that are collected from normal donors. And that can be, IVIG can be dosed every 1 to 3 months to maintain antibody levels at a level that, preserves some of your immunity. But that does add complexity to this otherwise simple therapy. While the drug itself is a simple subcutaneous injection once every 1 to 2 weeks, when you throw in the fact that you have to maybe get this antibody transfusion, this IVIG therapy every couple months, it does add to the burden and the cost and even a little bit the risk of the therapy. But we do think it's rather important, an important measure to reduce the risk of infection with Teclistamab, because we have learned that patients getting Teclistamab over the long term are at a significant risk of infection.
I can remember in the past that there were shortages of IVIG. Is that an issue anymore, or do we never worry about that anymore?
Yeah, there have periodically been shortages of IVIG. There were in certain parts of the during the pandemic. I think there were some shortages of IVIG. IVIG is quite expensive also, and it is one of those medications that we sometimes have to fight with insurance companies to get covered. We don't need to continue this medication forever, and so maybe it's a medication that can be given for 6 months, 9 months, a year or so. And our experience is that a lot of those patients, even after stopping treatment, remained without any myeloma progression for many months. And so that's something that we're we're starting that is going to be a focus, I think, of the next generation of clinical trials, trying to figure out, how long do we have to give these medications, and can we find a balance between that long-term infection risk and myeloma control with maybe a fixed duration of therapy. And there is another bispecific antibody that's being tested right now called Teclistamab that has a different target. And the way that those clinical trials were done with that medication was it was given for a year and then it was stopped. And that one's not FDA approved yet, but in December, we got some results from the initial clinical trial that tested it for a year and stopped. And we're starting to see how those patients are doing after they stopped it. And in the patients who had good responses, after stopping it after that 1 year of therapy, after stopping it, none of them have really had the disease grow back if they were in a good response before stopping it. And so that's really promising that maybe, as we learn more about these agents, we won't have to give them forever and deal with years and years and years of immunosuppression. Maybe we can give them for a fixed period of time and reduce that risk of infection.
I know there are other bispecifics being tested, like Teclistamab that you mentioned. And sometimes patients ask, why do we need more than one bispecific? What's the benefit of that for patients?
Yeah, so there are a few potential benefits. So I mentioned that both CAR T cells and bispecific antibodies, they need to recognize the multiple myeloma by a molecule on the surface of the multiple myeloma cell, and that the one that's been investigated most intensively is BCMA. The 2 CAR T cell products that are approved recognize BCMA, and Teclistamab recognizes BCMA, and there's a couple others that are in development that recognize BCMA. What we've learned, though, is that if you give a therapy that targets BCMA for long enough, the myeloma may get smart and just get rid of BCMA. And so what you'll have is myeloma that's growing, and the way it's evading the treatment is the myeloma has adapted and masked or turned off the BCMA molecule. And so the drug can't recognize the myeloma anymore. So what's great about some of these other bispecific antibodies that are being developed is that they recognize a different target on the myeloma cells. So even a myeloma that is no longer expressing BCMA might be recognized by some of these other bispecific antibodies. And so probably the next one to be FDA approved is a drug called Talquetamab. And that recognizes a molecule on the surface of the myeloma cell called GPRC5D. And we already know that there are some patients out there who have received Teclistamab and it stopped working, and they've gone on to get Talquetamab, and the Talquetamab has worked, suggesting that patients can really benefit from therapy with one bispecific antibody for a while and then have it stop working eventually, and then be able to move on to benefit from another bispecific antibody that targets a different target on the myeloma cell. And so we have Teclistamab and some others that target BCMA. We have Talquetamab that targets GPRC5D. And then probably the next one down the pike will be a drug called Teclistamab that I mentioned earlier that targets yet another surface of the a molecule on the surface of the myeloma cell, FcRH5. And so we'll have this toolkit of different potent immunotherapies that all recognize the multiple myeloma in different ways. And that gives us more shots on goal, you might say, or more ways to attack the myeloma with different targets, and makes it harder for the multiple myeloma to evade all the therapies we have.
So you mentioned earlier that both of the CAR Ts also target BCMA. So if I relapse from a CAR T, does that mean that a drug like Teclistamab is not really available to me because I may not have any more BCMA, or does the BCMA marker come back after a certain length of time?
That's an excellent question. And we're still learning a little bit about that, to be honest, because these are all new therapies, and we haven't had tons and tons of patients who have progressed on one and gone on to receive the other. But what we are learning is that, and this is, a little bit premature to say this for sure, but most patients who progress after CAR T cell therapy that targets BCMA probably still have some BCMA on their myeloma cells for a variety of reasons. And so we have seen and actually it's been studied and reported last year at the ASCO annual meeting that a small group of 20 or so patients who had previously received a therapy that targets BCMA, for example, a CAR T cell, if they go on to get Teclistamab, about 50% or so of them will respond. Now, that's a small number of patients, so maybe the actual percentage is a bit higher and lower, but it's not hopeless. There are, someone who progresses on a BCMA-targeted CAR T cell could potentially benefit from a BCMA-directed bispecific antibody. And there are even some results, the other way around, patients who have progressed on bispecific antibodies and gone on to respond to CAR T cells. And so it is worth considering, and this is, these are really kind of patient by patient decision-making processes that you go through with your doctor about whether it makes sense to try some of these. And we're starting to get more tools available. So there are some ways on a bone marrow biopsy to look and see whether your myeloma expresses BCMA. I hope in the next couple of years we'll have some blood tests that can even give us a hint at that, and so that we can be more sophisticated and precise in our treatment decisions based on some of these tests that we can do. We're not there quite yet, but it's definitely within reach.
You talked a little bit about this earlier, and I'm thinking about the patients who aren't near large medical centers like the University of Pennsylvania, or I live near Stanford. Do you think we'll have a chance of being able to get bispecifics within or from the community oncologists that I go to, rather than having to travel?
There are, but it might take a little while. That with any new drug, it takes a little while for physicians to get comfortable with it. Maybe certain patients who are maybe a little sicker and having more problems need to be in the hospital, but maybe your typical patient who is just starting to progress and not having major complications yet of disease progression, maybe those patients can safely be dosed in the outpatient setting with a lot of close monitoring. And so, these are some of the things that we'll figure out over time. It's still really quite early with the medication just being FDA approved last October.
And I'm not sure we mentioned it earlier, but it's only approved for patients who have had 3 or 4 prior lines of treatment, right?
Yeah, that's an important point. It's this accelerated approval really for patients who have had 4 or more prior lines of therapy, very similar to CAR T cells. And so really for patients who are running out of options. And that's because it's an accelerated approval, and it has only been tested in so far a phase 1 and a phase 2 trial. And so there are several other, big phase 3 trials going on that will, hopefully confirm that this is a good medication that helps multiple myeloma patients, live longer with the disease. And that, I think, will open it to use a little bit earlier on in multiple myeloma therapy, rather than having it be reserved just for the patients who are running out of options.
There's a group of myeloma patients that are more difficult to treat than others, and those are often referred to as high-risk patients. They may have some chromosome mutations or whatever to be defined as that. But how do these bispecifics and immunotherapies in general, how do high-risk patients do on these treatments?
When you're talking about a patient population that is in 4 or more prior lines of therapy, in some ways, those are all a little bit high-risk patients, right? Because, even if a patient was low risk, so to speak, when they started with multiple myeloma, 10 years down the road, after lots of prior therapy, that disease can be pretty aggressive. And so when you see response rates of 60+% with a single medication in patients who have had that much prior therapy, that includes a patient population that has aggressive disease, whether they were officially designated as high risk when they started with myeloma or not. We certainly, do see, for example, patients with extramedullary disease, so multiple myeloma that started to grow as tumors outside the bone marrow. those patients maybe have a little bit lower response rate to the medication, but still many of them do respond. And so this is still a real option to try for patients, even with some of those higher risk features like extramedullary disease, but the response rates might not be quite as high. And we're still waiting to see about how long these responses last and whether there's any meaningful differences between different groups of multiple myeloma patients. And so what was also really encouraging from the Teclistamab data is that if you look at patients who are responding to the medication, a year later, about 70% of the patients still have ongoing disease control. The medication's still working for them. And we're still kind of waiting to see how long that can go. So we have patients in our practice from the clinical trials who've been on the medication for 3 years and it's still working. Now, I bet that's another way, though, that maybe some of the higher risk patients will be different from the more standard risk patients, that maybe even though it's working for them initially, maybe the responses aren't going to last as long. As that's true of most myeloma therapies, that patients with more aggressive disease, they actually may respond really well to all the medications, but those responses may not last as long.
There are a couple of major conferences coming up.
Yeah.
Can I pick your brain? What are you expecting or looking forward to hearing about regarding bispecifics from those conferences?
I imagine we'll hear at ASCO some data on the use of CAR T cells in a little bit earlier line of therapy. And so I mentioned that, all these therapies that are initially tested in patients who have run out of options get tested earlier on. And we have had in the last 6 months or so, one of the publications on the use of Abecma, that was the first CAR T cell approved for myeloma, the first use of that drug in an earlier line of therapy, patients with 2 to 4 prior lines of multiple myeloma therapy. And this was one of the first phase 3 studies with Abecma, where they really compared Abecma to the standard therapy that you would give for these patients. And they found that Abecma worked better than the standard therapy. And we'll hopefully get some more data on just how much better and more detail about those responses. And I would look forward in the next year or so, 1 to 2 years, that maybe we'll start to get those kinds of studies being done with bispecific antibodies. And I know those studies are ongoing with bispecific antibodies. Maybe we'll start to see some of the results. So it's really exciting and it's going to be confusing for us physicians to try and figure out which one of these new therapies to use when, but overall it's really exciting to have all these new options coming down the pike so quickly for our patients.
So better treatments and perhaps being used earlier in a myeloma patient's treatment schema.
It's been a real pleasure to be here. Thanks so much for the invitation. It's so nice to speak to you, and I hope this was helpful to your viewers and the patients listening.
And thank you for joining us on The Patient Story. I'm Jack Aiello.